This is a very fast-moving abstract presentation. These will be 3-minute presentations and 3 minutes of questions, so everybody get ready. I'd like to introduce the moderators. Dr. Barry Rich. She is an associate professor of surgery and pediatrics at the Zucker School of Medicine in Hofstra Northwell. And then Dr. Elizabeth Wynn, who is at Dayton Children's as a pediatric surgeon. So thank you to our moderators, and we'll call Dr. Barry as our first, Dr. Rich as our first speaker.
Okay, so our talk is Improving the Patient and Family Experience in Pediatric Surgical Oncology. Thank you for the opportunity to present our work, and we have no disclosures. A diagnosis of cancer in children is extremely distressing for families, and the need for complex surgical resections may further intensify these feelings. The Family Advocacy Committee of the Pediatric Surgical Oncology Research Collaborative, or PSORC, made up of both pediatric surgeons and family advocates, performed this research to better understand the lived experiences of families making perioperative decisions and to further clarify how they navigate the surgical experience in pediatric surgical oncology. This work is important so we as surgeons can clarify and take into account what matters most to families in having these discussions, to improve patient-centered outcomes, and to help families feel better prepared to engage in surgical decision-making. A survey was created by a subgroup of the PSORC Family Advocacy Committee that was sent out to 48 social media support groups for childhood and adolescent cancers. The survey was opened for 2 months in 2022, and we received a total of 165 responses. The respondents were primarily the parent or caregiver, with a smaller percentage being the patient themselves or patient spouse. The median age of the patient treated was 8 years, and the respondents were from 36 states, but were treated in 31 states, most commonly Texas and Illinois. 70% of respondents had private insurance, and patients had a variety of tumor types, most commonly Ewing sarcoma and osteosarcoma. Just over a quarter of the respondents had metastatic disease, and the majority of respondents deemed themselves as survivors or in remission. Qualitative analysis was performed using thematic analysis and axial coding, which identified 6 overarching themes that were determined from several open-ended survey questions. 2 examples of the open-ended survey questions included, please describe your decision-making experience for the surgery, and what recommendations do you have for improving the surgical experience for both after and before the surgery? These themes included communication, honesty, patient stories, second opinions, interpersonal skills, and resources for information. And here you can see just a few examples of direct quotes from respondents reflecting each of these themes. And I'll give you a few moments to just review these comments. In conclusion, our survey identified key themes that should be incorporated in family discussions to enhance the family experience. Patients and families should be able to actively participate in surgical decision-making, and honest communication should be optimized. Families value patient stories, access to reliable resources, and openness to second opinions. The development of communication aids and decision support tools may address the concerns identified and thereby improve the patient and family experience in pediatric surgical oncology. Thank you.
Thank you so much, Dr. Rich. Do you have any plans for next steps with this work?
Yes, thank you for your question. So I think this is a first step. I think that we had a nice representation of families, but I think that there's a bias inherently by who is responding to this. If patients are already involved in support groups, they already have some sort of access. We had 70% patients with private insurance, but there were other demographics not listed that also demonstrated that this was a biased cohort. So I think it's a good start, but I think we also need to incorporate a larger group of families, and what would be important to all families, not just those that already are involved in a family support group and have access to social media. But that being said, we've had discussions about different checklists and communication aids to assist with families when they're in these difficult situations. Thank you. The next presentation is cisplatin-resistant high-risk neuroblastoma treated with Zika viral therapy confers a survival advantage by Dr. Joseph Mazur.
Good morning, everyone. It's still morning, yes. My name is Joseph Mazar. I'm a research scientist at Nemours Children's Hospital in Orlando, Florida. And today I'm going to talk to you about a project we've been working on for the better part of a decade, the use of Zika virus as an oncolytic therapy for neuroblastoma. So, a little background that no one really appears to need at this point. So neuroblastoma is a cancer that is derived from progenitor cells that are neuroblasts. And neuroblasts are basically immature neurons that are developing into mature neurons, but ultimately, in this case, mature into cancers instead. So ultimately, the tumor is a developing cell that never reached maturity. So neuroblastoma itself accounts for about 8 to 10% of all malignancies in children. It's the most common solid extracranial malignancy worldwide in children. Accounts for about 15% of childhood cancer-related deaths. Now, as a non sequitur, we have Zika virus. So Zika is a member of the Flaviviridae family, same family as dengue fever, yellow fever, Japanese encephalitis. Now, Zika virus itself is actually asymptomatic in human beings about 80% of the time, or actually about quite a bit more, but that's what's detected. But the remainder of cases are ultimately mild symptoms and are self-resolving. So a lot of our work has actually been in attempting to research the oncolytic effect or benefit of Zika in eliminating neuroblastoma. So the work I'm going to talk about today is some of our in vivo studies. So in this particular case, we were comparing matching pre and post neuroblastoma tumors isolated from patients and then introduced into mice as solid tumors. And so here I'm going to be showing a pre-treatment at diagnosis isolate versus a recurrent isolate. And so what we did is introduce solid tumors and grafted them, and then introduced a single dose of Zika virus at about 2 million MOI. And so what we found was usually within about 10 to 12 days, we'd get virtual total elimination of the tumor mass with no recurrence. In addition, the mice themselves were completely asymptomatic. So we compared this as a survival study and found that, generally speaking, we could get close to 100% survival of all mice treated with just a single dose. But the data I'm going to show to you today actually is involving chemotherapy resistance. And so we've done a dozen derivations or more of this combination, pre, post, MICN amplified, not amplified. So one of the big questions we wanted to ask was, what's the effect of chemotherapy resistance on Zika virus? Obviously, they're very different modes of operation, but nonetheless, this is significant for solid tumors. So we compared cisplatin-resistant versus non-resistant variants of neuroblastoma, and we did the same diagnosis again. So here what we have is a single dose of Zika virus introduced locally, and what we see is basically about the same effect. So our chemotherapy-resistant tumor is growing much more aggressively, much faster, but as far as Zika virus was concerned, ultimately the outcome was basically the same. So we lost one mouse. Again, the problem with doing a single injection to determine robustness of the effect is if you miss, the mouse then dies. We also compared this to recurrent tumors, and we found basically the same thing. Tumors are much more aggressive, grow faster even as a chemotherapy resistant, but ultimately the outcomes are the same. The single injection eliminates the tumor and no recurrence. So our conclusions. Well, both pre-treatment and post-treatment neuroblastoma tumors can be eliminated with a single dose of Zika virus in less than 2 weeks, and the mice are completely asymptomatic. Cisplatin resistance had no negative impact, actually, on the sensitivity of Zika to the treatment of the tumor, and this included both pre-treatment and post-treatment cisplatin-resistant neuroblastomas. In addition, overall, over probably as many as 20 to 30 different studies that we've done, we get about an 80% improved survival rate from a single dose of Zika virus, regardless of whether they're cisplatin resistant or not. So as future directions, obviously, it'd be nice to know the mechanism of action. We're tracking that down with next-gen sequencing. We have a pretty good idea, but there's upwards of 400 different genes in those networks, and so paring down precisely which ones are consistent is going to take some time. In addition, obviously screening additional models. We're working on orthotopic right now, metastatic and patient-derived xenografts. In addition, screen additional tumors. So we know it works on quite a few different pediatric cancers, not just neuroblastoma, and it's also effective against a couple adult as well. And I'll take questions.
I have a question. So in the abstract, it did say that you used athymic mouse models.
Yep.
My question is, without the immune response in those mouse models, how do you think the immune response would affect the Zika virus?
Actually, we've done them in a complete immune-competent mice, and we see exactly the same thing. What we found is that we've actually done this in NSG mice as well, so they're T-cell, B-cell, natural killer cell defective, macrophage and dendritic cell defective, and Zika does absolutely nothing to the mice. Now, mice are natural hosts for Zika virus, so they can be infected by mosquitoes, and they can pass to mosquitoes. But there was actually a paper from UNC Chapel Hill that showed that if you knocked out or inhibited type 1 interferon functions, the mice could pass in about 7 to 10 days. So really, type 1 interferon is the only thing that's actually regulating the virus in these hosts.
Great talk. Tim from Chicago. Is there a path to converting this into a therapy that could be given systemically?
Absolutely. That's where we're working on the metastatic. So the way we designed this based on COG protocol was to basically follow induction therapy as a bridge therapy. So for these experiments, it's intended to be local, so local injections. The advantage is the virus does all the tracking for us, and so what we find is that the mice are completely asymptomatic. There's no inflammation, there's no immune response whatsoever, regardless of whether they're completely immune compromised, as long as type 1 interferon appears to be functional.
Hi, thank you for the paper. I would like to ask if you envision something when translating this into clinical practice about the toxicity for the neurosystem in children, because for pregnant women there is microcephalia.
Sure. So Zika virus's effect actually on children literally at birth appears to have no effect whatsoever. This is only fetal. So some of the arguments for that are the ability of Zika to pass the blood-brain barrier. Some have indicated that they can get some passage, but ultimately we don't see encephalitis, right? So at the point of birth, type 1 interferon has to be functional, because if it were not, babies would die to any viral infection within a week of birth. And so as long as they have type 1 interferon functional.
That's good.
Yeah.
Okay, thank you.
Thank you.
All right, thank you, Dr. Mazar. Next up, we'll have characterizing renal sarcomas in children in a large North American cohort, a pediatric surgical oncology research collaborative study with Dr. Caitlin McKay.
Good morning. My name is Katie McKay. I'm a second-year general surgery resident at Vanderbilt, and I'll be presenting our work on pediatric renal sarcoma on behalf of the Pediatric Surgical Oncology Research Collaborative, and we have no disclosures. Renal sarcomas arise rarely in children and adolescents, comprising approximately 6% of pediatric kidney cancers, and represent a histologically and biologically diverse disease category. Clear cell sarcoma is the predominant histology type. However, multiple other sarcoma types exist, which makes standardizing optimal therapies for these patients very challenging. Leveraging a large North American research collaborative, the purpose of this study was to evaluate the current state of patient and disease characteristics, treatment strategies, and overall survival. Patients 21 years or younger who were treated for a primary renal sarcoma between 2000 and 2022 were identified through the PSORC. Patient and disease characteristics were abstracted from 32 contributing institutions. Among the 158 patients identified, clear cell patients predominated at 94, Ewing sarcoma contributed 33, undifferentiated sarcomas had 8, and rhabdomyosarcomas had 7. There were 10 other sarcoma types included, which included infantile fibrosarcoma, synovial sarcoma, and even rarer subtypes. Sarcoma type did correlate significantly with age at diagnosis, with infantile fibrosarcoma and clear cell sarcoma occurring in the youngest patients, whereas Ewing sarcoma and synovial sarcoma presented in the oldest, respectively. Somatic molecular alterations were documented exclusively in clear cell at 34% and 79% of Ewing sarcoma. As far as treatment strategies, multimodal therapies varied significantly across sarcoma type, although definitive nephrectomy was constant at 87%, with 82% of those being upfront. Tumor thrombectomy was performed in 9 patients, 6 of those being patients with Ewing sarcoma. Overall survival at 4 years varied significantly with sarcoma type, with clear cell at 92.6%, Ewing sarcoma at 90.1%, undifferentiated sarcoma at 83.3%, infantile fibrosarcoma at 67.7%, and rhabdomyosarcoma at 50%. Overall survival for patients at 4 years with or without metastases was 95.7% without metastases and 71.7% with metastases. Overall, survival at 4 years appeared most dependent on the unique histology, the stage of diagnosis, stage of disease at initial presentation, and the metastatic pattern. Renal sarcomas presenting in children and adolescents comprise a diverse disease category with unique patient, clinical, and molecular characteristics that complicate standardizing therapeutic strategies beyond clear cell and Ewing sarcoma. Thank you.
Thank you for your talk. In the abstract, you mentioned investigating different molecular analyses. Were these all the same analyses, and did they have the expected effect?
Yeah, great question. So in our analyses for the molecular alterations, only clear cell and Ewing sarcoma had molecular alterations that came out. I think part of the bias likely is that it's a population from 2000 and 2022, so the ability to be able to detect those has probably changed over that time, and I think that's something that going forward can be looked into further.
Thanks. Great. Nice job. Thank you. The next presentation. Okay, the next presentation will be early removal of indwelling urinary catheters in children undergoing abdominal tumor resection with epidural analgesia, presented by Dr. Sachi Srivatsa.
Thank you. Good morning. My name is Sachi Srivatsa, and I'm currently the Surgical Oncology Research Fellow at Nationwide Children's. Thank you for the opportunity to present this work today. We have no relevant disclosures. There are no current evidence-based guidelines for the routine use of postoperative indwelling urinary catheters in pediatric patients receiving epidural analgesia. I'm presenting this research because it addresses a critical aspect of pediatric postoperative care, aiming to contribute to enhanced recovery efforts by optimizing the timing of urinary catheter removal in this patient population. Epidural analgesia is commonly utilized for postoperative pain management in children undergoing abdominal tumor resections. However, due to concerns of urinary retention, this often leads to the prolonged presence of indwelling urinary catheters, which may hinder early recovery efforts. This study aims to assess whether the early removal of indwelling urinary catheters while maintaining adequate epidural coverage poses minimal risk of reinsertion due to urinary retention in this patient cohort. To conduct this study, we performed a retrospective review of children undergoing abdominal tumor resections with epidural analgesia at 2 institutions with varying practice patterns on indwelling urinary catheter removal. Early was defined as catheter removal with epidural in place, and late as urinary catheter removal after or concurrent with epidural discontinuation. The rates of postoperative urinary retention and catheter-associated urinary tract infections was compared between the 2 groups. Our patient cohort comprised of 229 children. Of these, 104 had early removal, whereas 125 had late urinary catheter removal. The average postoperative day of indwelling urinary catheter removal was 1.1 days in the early removal group and 2.9 days in the late group. The average postoperative day of epidural removal was 3.2 days in the early group and 2.7 days in the late group. In the early removal group, epidural was predominantly at T12 or higher and contained opioids less frequently than compared with the late removal group. Notably, the risk of urinary retention requiring catheter reinsertion was small in the early removal group, but did reach statistical significance when compared to the late removal group. There was no significant difference in the rates of urinary tract infections between the two groups. We conclude that the early removal of indwelling urinary catheters in the setting of thoracic epidural analgesia is associated with a slight increase in the risk of urinary retention requiring catheter reinsertion. However, this must be balanced against the benefits of early removal for enhanced recovery efforts. And moving forward, decision-making regarding the timing of urinary catheter removal should consider patient comfort, infection risk, and the possibility of urinary retention. Further research should delve deeper into optimizing postoperative care protocols to align with enhanced recovery initiatives. Thank you.
Thank you so much for that great talk. What determined early versus late in the group? Was it surgeon preference or other practitioners, or how it was a retrospective study, so were you able to elicit what determined when it came out?
So it was a combination of two things. At one institution, so at Nationwide Children's, the typical practice is if the epidural is placed at T12 or higher, then it is okayed by the anesthesiologist for the catheter to be removed either intraoperatively or postoperative day one. But there is also surgeon discretion to that. And then at St. Jude's, the typical protocol was to keep it in place while the epidural was there.
Hi, nice presentation. Did the study cohort also include renal tumors?
It did.
And was there any difference in those? Were they relegated to the late pull as opposed to the early?
So we went through and we did not see any significant difference between the two groups based off of a pathologic diagnosis.
Was there a difference in the length of hospital stay between both groups?
Sorry, what was that?
Was there a difference in the length of hospital stay in both groups?
So unfortunately, we did not look at hospital stay. It's something that's been looked at in the literature, especially in the adult literature, but we did not look at it in this particular study, but it'll be something that we look into in future studies.
Thank you.
Thank you.
Great, thank you. Next, we'll have characterizing congenital mesoblastic nephroma in children, a pediatric surgical oncology research collaborative study, presented by Dr. Lisa Tracy.
Hi, thank you. Thank you very much to IPSO for putting on such a great program today, and thank you all for listening. My first disclosure is that I am actually not Harold LaRosse, who is the first author on this study, but I am the lead researcher on the rare renal tumors team through the IPSO collaborative. I'm excited today to talk a little bit about characterizing congenital mesoblastic nephroma in children, and the motivation for collecting this group of tumors was that this, although congenital mesoblastic nephroma is a rare renal tumor of infants, and although the survival, especially for the classic subtype, is excellent, those with other subtypes, especially the cellular variant, can have worse outcomes. We aim to describe the presentation, treatment, and outcomes based on histologic subtype of this tumor in a study that allowed us to gather data from institutions across the country. So we did a multi-center retrospective study through PSORC. This was part of the larger rare renal tumor study. We collected data on children under 21 years of age with renal tumors, which were diagnosed in a contemporary cohort over the last 20 years. Descriptive statistics and Kaplan-Meier methodology was utilized. And what we found was that from our cohort of over 2,000 children with renal tumors, 91 children with CMNs were identified. This is about 4% of renal tumors, which is consistent with published frequencies. We had 32 who had a cellular histologic subtype, 31 classic, 1 mixed type, and 17 other variants, which were either rare or unspecified. Median follow-up time was 48.5 months. Most of the, or about a quarter of these, I should say, were discovered prenatally, and over half presented postnatally with symptoms. We had a handful which were also diagnosed incidentally on imaging. So what we found were that we had molecular and genetic variants, which were most common in the cellular CMNs, rarely in the other subtypes. Most tumors, as everyone in this audience would expect, were completely resected at diagnosis, and overall patients did well. 16 children demonstrated aberrant fusion at INTREC. 3, only 1 child received targeted therapy with an INTREC inhibitor. And 2 patients with cellular CMN received neoadjuvant chemotherapy, followed by delayed nephrectomy. As we can see here, our data, this study allowed us to gather some very granular data on these various subtypes. But the most significant finding, of course, is that for most of the children, survival is excellent, but for the cellular subtype, it's not. And these are the children who could really benefit from more intensive treatment strategies and from us thinking a little bit more strategically about treating these children when they're identified and identification of the subtype. So again, CMN's a rare renal tumor with an excellent prognosis for most children, especially those with the classic subtype. And although survival is excellent, the cellular variant has increased molecular rearrangements, could be a target for targeted therapies, but is also is associated with increased risk of mortality. So identification of these children and discussion of whether they would benefit from neoadjuvant or adjuvant therapy or targeted therapy should be an area of future focus for this rare renal tumor. We'd like to thank all of the centers who collaborated in this study across North America, and to the IPSO Research Collaborative for allowing and facilitating this study. Thank you.
Thank you. Was there any overlap between those who underwent the neoadjuvant chemotherapy and those who relapsed with the molecular rearrangements?
That's actually an excellent question. We do have granular enough data to answer the question. I just don't have the answer for you right now, but we can do that in the manuscript. Thank you.
The next presentation will be blood transfusion during surgical resection of hepatoblastoma is independently associated with poorer overall survival, a pediatric surgical oncology research collaborative study by Dr. Stephanie Please.
Hello, thank you to all of our collaborators in PSORC as well as the opportunity to present here. So we know that many children receive allogeneic blood transfusions during cancer surgery, especially liver resections and other big operations. We also know that in numerous adult solid tumor resection, transfusion has been associated with worse long-term outcomes, specifically survival. This is presumed to be due to immune and inflammatory mediated processes by allogeneic transfusions, and the tumorigenic cause and effect relationship has been shown in preclinical rat models. The association between intraoperative blood transfusion and short-term outcomes is known. There's some excellent NISQIP data that showed it is associated with increased short-term morbidity, but the impact on oncologic outcomes is unknown. So the hypothesis of this study was that intraoperative blood transfusion would be associated with worse oncologic outcomes in children undergoing resection of hepatoblastoma. This was a 19-center retrospective study within the Pediatric Surgical Oncology Research Collaborative. Intraoperative blood transfusion, or IBT, was considered a yes or no exposure variable and included any PRBCs, plasma, or platelets administered intraoperatively. To adjust for non-random assignment of intraoperative blood transfusion and center effect, we did inverse probability treatment weighting. We did Kaplan-Meier and Cox survival analyses for our primary outcomes of disease-free and overall survival. Of 338 children who underwent resection of hepatoblastoma, 76% received intraoperative blood transfusion, the majority of which were packed red blood cells, with lesser receiving plasma and platelets. Median follow-up was for 0.4 years. So this is a little bit of a deep dive into the transfusion characteristics, sorry for this, but preoperative transfusions were equivalent between the groups. Preoperative hemoglobin was lower in the IBT group, however, platelets and INR were similar. The lowest intraoperative hemoglobin, as expected, was lower in the IBT group, and patients seemed to be a little bit more coagulopathic with lower platelets and higher INR. The immediate and 72-hour kind of nadir post-op hemoglobin was higher in IBT patients, and nearly 10. And of note, post-operative transfusions, early post-op transfusions were greater in the IBT patients, but these were not red blood cell transfusions causing the difference. Those are the same. It was because they received more plasma and platelets. As expected, patients with more extensive tumors and more complex resections, unweighted, had more IBT. This is showing that after the weighting, these groups were equivalent. Short-term outcomes, briefly, weighted and unweighted postoperative ventilator requirement and surgical length of stay was greater in patients who required IBT, which is consistent with prior NSQIP data. This is the primary outcomes. On the left are survival curves for overall survival. Overall survival was less in patients who underwent intraoperative blood transfusion. If you can't see, the y-axis is 80 to 100%, not 0 to 100. And then on the right is disease-free survival, which was equivalent. And this held true on multivariable analysis, which accounted for, among other things, transfusion exposure at other times during therapy, such as neoadjuvant or adjuvant therapy. So the limitations were primarily that this is a retrospective study, so there was a lot of granular transfusion information that I would have loved to have, but it just wasn't practical to collect. However, we can conclude that intraoperative transfusion was associated with worse overall survival in children who underwent resection of hepatoblastoma. We can also conclude that there were likely avoidable transfusions and that the transfusion strategy intraoperatively was PRBC dominant. Which I think supports the need for further research into the mechanism behind the association with outcomes, and mainly the immunomodulation, avoiding unnecessary transfusions, and specifically not using laboratory values such as hemoglobin alone intraoperatively as a trigger, and then alternative transfusion strategies, some of which I've listed here. Thank you very much again to all of our collaborators who contributed data to this study.
Thank you so much. That's really terrific work. My question is, the pre and post-operative blood transfusions, I guess if you would recommend patients to not have intraoperative transfusions, but then have more pre or post-operative blood transfusions, do you think that would have any effect? Or do you think it's primarily the intraoperative transfusion that's causing the change?
And I think, thank you for your question. This is one of the things, we did collect sort of the timing of the early pre and post-op transfusion, so I think one of the next steps is going to be looking at is the outcome the same if you consider those separately, altogether, trying to parse it down a little bit more for this. We just wanted to see, is it there at all in this pediatric surgeon population, but I really want to know that as well. There is a really great paper from Europe in adults with gastric cancer where they found a similar association and then actually instituted this pre-op protocol to try to avoid transfusions, where they started things even a month in advance to try to bump up the hemoglobin. So I think the hope is to potentially avoid some of these allogeneic exposures altogether, intra-op, immediately pre or post-op.
Great, thank you.
Next, we have Textbook Outcome, a novel quality measure for surgical management of neuroblastoma with image-defined risk factors, with Dr. Tariq Zaghloul.
Thank you very much for allowing me the time to present today. I would like to thank also the whole group who worked with us at St. Jude Children's Research Hospital. So we have no disclosures. With the increasing audit of results and improvement in quality of care across healthcare institutions, we found that the Clevin-Dindal classification, the hospital stay, and readmission rates are all single measures that cannot be used to assess patient outcomes. And here comes the question, what can hospitals and providers do to change and improve their outcomes, and how can we measure that in a better way? So the textbook outcome was found to be a composite quality measure for desired patient outcome, where it incorporates some factors that if all of them are met, then we can say that the patient had a textbook outcome. These variables include absence of complications, no mortality, no 30 days readmission, no prolonged hospital stay, and resection, basically oncologic resection, and for neuroblastoma with IDRFs, it's resection of more than 90% of the tumor. Textbook outcome was used in other surgeries, mainly in the adult side of the world, including liver surgeries, bariatric surgery, cardiovascular, and transplantation. And to my knowledge, it has been used in a few pediatric studies as well. So why is that important? First of all, that provides a metrics for individual hospital differences in achieving textbook outcome, explaining which individual indicators is mainly responsible for the outcomes and could be improved, giving information to patients and their families about what to expect and the overall outcomes, and having insights on the overall care process. And all of that will definitely result in an improvement in quality of care. So our study included 248 patients that had neuroblastoma treated between 2012 and 2022 at St. Jude Children's. Out of those, 69 patients had IDRFs. Of those, 46% achieved textbook outcome, and about 53% did not achieve the textbook outcome, either due to complication, readmissions, prolonged hospital stay, or resection of less than 90%, but we did not have any mortality. There was no difference in the demographics among both groups, and we only found that high-risk neuroblastoma was more associated with not having a textbook outcome. At the same time, not surprisingly, having more IDRFs would predict not reaching the textbook outcome. We also found that there are factors that negatively impact the textbook outcome, included duodenal-pancreatic block infiltration, kidney infiltration, IVC encasement, and porta-hepatis involvement. And we found that the postoperative complication was the leading barrier to achieve the textbook outcome, where about 80% of patients had a Clevin-Dindal classification of more than 1, but thankfully there was only 11 patients who had a Clevin-Dindal classification of more than 3. So we conclude that the textbook outcome is a measurable quality standard that can be utilized in institutional quality audits, which can highlight areas for management improvement. And we hope that there will be national, international studies to assess the textbook outcome across diverse institutions, which could represent a step towards improving the quality of care and standardization. Thank you very much.
Thank you for your talk. I was wondering how you're planning on seeing this used in everyday life for a surgeon. Are they going to be reporting their textbook outcomes based on image-defined risk factors, or will it be more broadly based for all surgical oncology cases at that institution?
So I think that's what's happening right now, is that each disease site is trying to get their own textbook outcomes, so that we know that definitely for patients with high-risk IDRF positive patients don't have the same expectation like a non-IDRF patient. So if we have a standard for each disease site and each disease status, then we can adjust accordingly and know what to expect and then improve. All right. Thank you.
And our final presentation will be perioperative antibiotic use in pediatric solid tumor resection, presented by Dr. Huma Halpota.
Good afternoon. Thank you for giving me this opportunity to present my work at annual IPSO conference. I have nothing to disclose. Currently, there is no worldwide agreement on the use of the perioperative antibiotics in pediatric solid tumor resection, and there is differential use of antibiotic based on the hospital setting and characteristic of the patients. My study is a retrospective cohort study in which I have compared two institutes. One is Leeds Children's Hospital, where there is a routine use of antibiotics. There is no routine use of antibiotics. And another is the St. Jude Children's Hospital, where there is a routine use of antibiotics. The main objective of my study was to investigate the incidence of post-operative sepsis and infectious complication according to the perioperative antibiotic use, and the primary outcome which I have looked were the wound infection or the systemic sepsis within 30 days of surgery. During this study period, 250 patients were included in this study. Median age was 4 years. The most of the operation were the open surgical procedure, and the most common tumor location was renal, followed by adrenal. 75% of the patients in this study received antibiotics. However, 25% didn't receive the antibiotics. And the use of the antibiotic was significantly differed with the hospital setting as well as with the use of adjuvant chemotherapy. The most important primary outcome which was significantly associated with the use of the prophylactic antibiotic was the post-operative sepsis within the 30 days of the surgery, but there are no significant wound infection have seen in this cohort because of the low number of wound infection in this study. The logistic regression models predicts the outcome of developing sepsis was significantly associated with the surgical timing, use of adjuvant chemotherapy, and the prophylactic antibiotics. So we have concluded that antibiotic prophylaxis in children undergoing solid tumor resection is associated with lower incidence of post-operative sepsis, but it does not affect the post-operative wound infection. Our results suggest that using the antibiotic prophylaxis in children undergoing solid tumor resection should be standardized. Thank you.
Thank you for your great talk. My question is, were there any differences in the groups in terms of neutropenia or chemotherapy, preoperative neoadjuvant chemotherapy? And similarly, in the sepsis groups, were there any difference in terms of central venous access or lines? I'm curious if any of the other aspects were different between the groups.
Sure. Thank you for this question. Actually, the central venous line was almost same in both the institute. We used the Hickman line as well as the port in both the institutes. So no, there was no difference in terms of the central lines. But in terms of the neutrophilia, whenever we think the ANC count was more than 500, then they went for the surgical tumor resection.
Great. Well, thank you for such a wonderful session.
Thank you.
Great job.